issues: informed consent, disclosure, and family decision-making. It has often struck me as ironic that these are the most vexing problems facing those of us who work with patients who suffer from dementia, yet they consistently receive the least discussion, perhaps because they are so problematic. How do we take people who are used to functioning independently all their lives, frequently to running families, raising children, and then start to take their authority away from them and try to protect them against errors that they may make themselves in running their lives? These are very, very difficult decisions, not only involving ethical and legal issues, but also involving human dignity. That is, how do we treat people with grace and dignity as they suffer from an illness which consistently impairs their judgment and leads to frequently depression, delusions, and clouding of consciousness, which may make it difficult for people to live independently. We're fortunate this afternoon to have an excellent panel to discuss several cases on these very issues. We have Ms. Betty Gregg, who is a caregiver who has lived day to day with the suffering that Alzheimer's disease can force upon families, and who has practical experience with the kinds of issues that we're going to be talking about this afternoon. We're fortunate also to have Dr. Gerald LaRue. Dr. LaRue is an adjunct professor of gerontology at USC and an expert in the ethical issues that are facing dementia patients, caregivers, and those who work, professionals who work with patients with dementia. We also have Ms. Sheila Moore, who is a social worker at the Center for Geriatric Health at Century City Hospital. Ms. Moore, as a social worker, also works frequently with families dealing with the kinds of issues that we're going to be confronting today. We have Dr. Laura Mosqueda. Dr. Mosqueda is a geriatrician, an associate professor of gerontology at USC, and frequently works with families who are struggling with these kinds of issues that we're confronting. Lastly, we have Dr. Stephen Reed. Dr. Reed is the Deputy Director of the Upbeat program at the West Los Angeles VA Medical Center and formerly Medical Director at the French Center for Alzheimer's Disease in Los Alamitos. And Dr. Reed will be bringing it to us this afternoon the perspective of the researcher dealing with Alzheimer's patients and their families. The format for this afternoon is relatively simple. We have 3 cases which you should have in your books in front of you. What I'll be doing is reading these cases and then inviting the panel to participate in a discussion of the issues which these cases present. I've asked one of the panelists to go first to discuss each of these cases, but all the panelists are free to jump in at any time and put in their perspective as well. Since we have a number of panelists, a number of cases, and we also want to leave time for discussion at the end of the afternoon, I'm going to ask people to keep their remarks relatively brief. With that, I'll go ahead and start with case 1. Mr. X is a 64-year-old male who presents to the Memory Disorders Clinic complaining of mild forgetfulness. Although he continues to work as a salesman, he complains that he has greater difficulty remembering names and recently has forgotten several important appointments. He states that he is afraid that he is getting Alzheimer's disease and he wants to have a complete workup. You take a complete history, perform a physical examination, order a complete battery of laboratory tests as well as neuropsychological testing. In addition, Mr. X agrees to participate in several research studies which involve having a positron emission tomography or PET scan as well as ApoE4 testing. The clinical evaluation of Mr. X shows some mild cognitive changes which are somewhat greater than expected for his age, but not clearly outside of normal limits. You meet with the patient and his wife and tell them that the results of the evaluation are inconclusive. Mr. X becomes agitated and says that he came to see you to get some answers. He tells you that he consented to participate in research to get the latest tests available. He heard that experimental tests that he had, specifically the PET scan and ApoE testing, can help to establish the diagnosis, and he demands to see the results. The consent form that he signed says nothing about the patient being entitled to view test results, but copies of the results are available to you. What do you do? This is a case that I think poses difficult issues in terms of, well, on several fronts. When are research procedures really ready to move into the realm of clinical use? When we have uncertain information that may affect how a patient views themselves, when we have information which may be informative to the patient but not really clearly clinically relevant, do we give that to the patient? I've invited Dr. Reed to comment on this case first.
I'm not sure if I should thank Dr. Luther or not. I appreciate the opportunity, and I could make this easy on myself and say that if I'm speaking as the researcher in this case, the question as posed, I believe, is posed to the clinician. And so I can wash my hands and say that it isn't my problem. Of course, that would be dodging a little too much. I think the case does raise several important issues. One is an issue that we've discussed today several times, is the issue of what informed consent means in this kind of situation. Clearly, the agenda of someone who consents to be involved in research, even if there is no question of cognitive capacity, may have an entirely different agenda from the researchers themselves. And there might be some question as to whether there was a full sense of information and appreciation, as we heard Ms. Scott discuss earlier this morning in this case, particularly with respect to whether the information would or would not be available to the patient. The other challenge in research programs is what do you do when a patient, assuming that the informed consent was true and valid, that patients can, of course, change their mind. And Walt Whitman said we all have the right to change our mind. That's not always allowed for in this situation. And in this situation, it's a very tricky matter. As a researcher, I could anticipate a call from the clinician, and the question is, what would I say? The first thing I would say is if I have released this information to the clinician, then I'm not sure that I would expect that to be confidential from the patient. And so in this particular instance, I think the circumstances of the case suggest that the horse is already out of the barn door. Are there circumstances where research information properly should be kept from patients or from research subjects? And that's been a very difficult matter. As Dr. Luther alluded to, there are times where we have findings which we don't know how to interpret. And the concern from a research point of view is that a finding may be misinterpreted not only by the patient, but possibly by family, possibly by people otherwise involved in the clinical care. For the two tests in question, these are very much tests where I think the dilemma posed in the case as presented would have been a more painful dilemma several years ago than it is now. As it happens, both of these two tests are commercially available, and there are proponents for using them in a diagnostic manner. And so I think the sanctity of the information for these two tests may not be quite so great. The other, I think the more difficult issues in this case, I will leave to the other panel members because I think they are what someone in this situation who fears having a terrible illness, what that information, what seeking a diagnostic opinion means to that patient, and what are the consequences of affirming, disaffirming, or leaving ambiguous the diagnostic results. So with that, I think I'll turn it back to Dr. Luther.
Actually, just allow me to make your life more difficult for a moment and pose another question to you. We have a test with ApoE4 that tells us what the risk at any given age of getting Alzheimer's disease is. If one, let's say, is an ApoE4 type, that the risk of having the disease is never 100%, but can get really quite high by the age of 85. I think it's 95% at that age. Should we be telling people that kind of information? That is, if somebody comes in with mild memory deficits, we don't really know clinically what that patient has, but we know they have an ApoE44 type. If we give them that information in the face of mild forgetfulness and no clear diagnosis of dementia, are we doing anything more than giving somebody a license to worry?
Once again, my bias is to pump this to the clinical people, but I will speak as a clinical person in my own, and I'll be curious what other people on the panel would do with this information. Dr. Roses at a symposium last fall actually proposed that we obtain ApoE4 testing as a diagnostic test. Essentially in this kind of situation, if I understood him properly, he would feel that it would be appropriate to obtain the test, and that a positive test was essentially, in a clinically suspect, potentially ambiguous case, was very weighty in terms of diagnostic import. My personal reading of the ApoE data is not nearly that firm, and so, for example, I don't encourage people to get ApoE testing precisely because I don't know what the results mean. Cynically, the evidence is that people with the ApoE4 double allele are probably more likely to die of cardiovascular disease before the question of Alzheimer's disease arises in their lives. So that's another separate issue for them. I think for ApoE4, however, we can fill in a variety of experimental procedures. We live in an area where people may be invited to participate in a variety of research studies, and I think handling ambiguous information is difficult. I think the crucial issue in this case is what this means to this patient, and that's why I think maybe the major issues are that it is unlikely that any of these tests is going to give you a 100% answer.
As a caregiver in this particular situation, early in the game, early in the diagnosis, as far as my husband is concerned, for me, it would have been a devastating thing to hear any more than the doctor told me at that time. I think the doctor, and this is a very naive way of looking at things, I think the doctor has to be the judge of just how much, on top of everything else the couple is going through, just how much they can take at that time of information and how much they need to know at that time of the diagnosis, because nothing is going to change. And as you get further along with this, and as a caregiver, as you get a little more experience, you're able to handle the information a little better. You have a better knowledge of what the disease is, what it means. Education is a wonderful thing as far as this disease is concerned. And so that would be the only thing I could say on it, how much I could have handled at that early stage.
If I can ask, let's take a slightly different case where a patient comes in and the physician's quite certain of the diagnosis of Alzheimer's disease. Everything points to it for whatever reasons. Mm-hmm. And the physician feels that the patient and his or her spouse, may not really be ready to hear that information. Then the physician says, I think that these people are overwhelmed right now, but he is certain of the diagnosis. Should he withhold that information at that point?
No, I don't think so. The information wasn't withheld from us, for me. It was more the way it was presented. And when we got the diagnosis, it was, of course, a blow, but I think both of us had anticipated that that's what it would be. But that's all I wanted to know at that time.
Right. Okay.
I didn't want to be educated completely. I wanted just to deal with what I could do. I was dealing with so many things at that point. I didn't need any more information than that.
Right.
So I think you have to be very careful about how much you load on a family as well as the patient.
Okay. Thank you.
I think there's another issue, and that is the paternalistic attitude of the clinician saying, well, I have decided that this is something that might overload the person. I think your point was well taken. Enough information to assure that this is what's taking place. And if I was the victim, I would want to know, or the patient, I would want to know what the diagnosis with. I might have plans that I want to make. I might want to make closure with a lot of people. I might want to get rid of a lot of stuff that I've been saving and all this sort of thing. It gives me a chance to finalize some aspects of my life before the dementia takes over.
I think that, what we're hearing is that it's very individual. And I have some patients who come in who are the type of people who want to know everything. And the minute that a diagnosis is given, they are on the internet and they're in the library. And by the time they see me a week later, they know much more about it than I do. And then there are some people who want to put their hands over their ears and hum, so that they don't hear anything that I'm going to tell them, because they're not ready to hear it. And so I think it does need to be done with some sensitivity and some caring, and to understand what people are ready to hear. So with me, I'm often sitting down and asking people questions before I'm answering questions to get a sense of what people are ready and willing to hear. I think the danger of this paternalistic approach of saying these people aren't ready to hear it yet is that sometimes we physicians can use that as an excuse because it's too hard for us to give bad news to somebody, and so it's really easy to say, well, they're not ready to hear it, so I don't have to deal with my fear of telling somebody bad news. And I think that's something that we need to guard against and make sure that it's not an excuse.
From a social work perspective, I'm a social worker who believes dealing with families and individuals who are diagnosed with Alzheimer's disease, that really the only way to cope is to know as much as possible about the disease process. And I think that I feel an obligation to clients to provide them with as much information as possible, and that their mechanisms of defense, like denial, will naturally protect them from what they can't or aren't ready to hear. Some of the other issues that struck me as I read the case was this is a highly motivated gentleman to come in on his own seeking answers to these questions about his memory problems. Most of the people that we see at the Center for Geriatric Health are being brought in by their family members, so I was struck by that. The others, some of the panelists have already addressed, are what might be the consequences of disclosing this information, not only to the individual, to the I guess we would call him the patient, to Mr. X in terms of his outlook, but as well, what's the effects on his wife in terms of immediate future. You know, I always think about the consequences after we give a diagnosis of Alzheimer's disease, and now the family member takes this person back home. I always wonder, what's the conversation in the car like? What is it like now at home? Do they perceive now everything is different from that point on? So I think that kind of weighs heavy, as well as long-term planning. Again, I believe that families need to know as much as they can to make those choices that ultimately will have to be made.
I'd like to just refocus the panel for just a second, because several of you have commented on the sharing of information with from my perspective, the assumption that we know what that information means. That is, if we know about a diagnosis, if we have a diagnostic test that we understand, that's one category of information, and my personal perspective is that we're obligated to share that with the patient. When we have information, though, that we're talking about here, which is for tests which we don't understand, some would argue, ApoE4 testing, we know that it confers a certain risk upon that individual for getting Alzheimer's disease, or as Dr. Reed pointed out, for dying of cardiovascular disease. And I, too, was at Dr. Rose's presentation last fall where he said we could use this diagnostically. But there is debate on those points. And I think that most people would say that we don't know what an ApoE44 type means early in the course of dementia. So if a patient wants information which we ourselves don't know how to interpret, how do we handle that? What do we tell the patient at that point?
Well, but before, or maybe instead of answering that question,
feel free.
I think that part of the problem is that when we talk about, I think you asked, who when a research tool gets moved into the clinical realm and it's used in a clinical setting. And I think it's unfortunate that it's us, quote, experts who are making that decision. I think that caregivers and society in general needs to be involved in making that decision too. And that it tends to be the scientists who decide when things are ready to move along. I think it would be a very worthwhile community-based discussion to find out at what point ought we use things like ApoE4 clinically. And it shouldn't be confined to the scientific community to make that decision.
Well, the problem is that, as Dr. Reed pointed out, it's available now. So, panel, what do we do?
Well, I know some people that have decided to get ApoE4 testing on themselves in terms of the decision as to whether by long-term care insurance or not, for example. So there's mileage on both sides of this, however you interpret it. I would go back, and now speaking more as a clinician, and I think one of the nice things I thought in this case is, as Moore pointed out, was that the patient's wife was already involved. And that can be a difficult issue. When a patient does come to you, it is best, if at all possible, you can involve other people in that family and make them a part of the decision. I think a lot of the fear that the distress that brings this patient in is a fear of what this will mean for these others in my family, in many cases, in my experience. I also find that the anxiety and the fear of a diagnosis, maybe I'll illustrate this. The most painful case I had in this line was a man who came in and said that he wanted to know if he had Alzheimer's disease, but he told me if I told him he had Alzheimer's disease, he was going to drown himself. And he lived on a boat. So this was not a faint threat. And he was going home that evening to get on his boat. And grimly enough, he had Alzheimer's disease. And he was very alert, and I would have fit this fairly well, except that he retired. And what we were able to deal with was the only Alzheimer's disease he knew was a friend who was moribund in a nursing home. And there were a lot of preconceptions, and this was a gentleman that this was when I was in Los Alamitos, and he became involved in several programs at the French Center and other programs in the community. I was able to refer him to an experimental drug study protocol, which, truth be known, didn't benefit him terribly much as a direct biological effect, but did serve to he felt involved not only for himself but for others, and I think those kinds of issues, and also related to what we talked about today, this is when you talk about durable power of attorney and what is it that you're worried about, what things need to be taken care of. I'm trying to echo Dr. LaRue here that there are concerns people have. I tell people to take the vacation that they're waiting to take, and when they come back, we'll reevaluate.
Is it possible, from the point of view of a scientist working in this field, to say, and this is, I understand, a typical scientific approach, this is what we think we know in the light of the evidence. We could be wrong, there are alternative interpretations of this, but I want you to know the variables that are associated with these tests. We can't definitely say to you, this is what you've got, this is Alzheimer's, definitely. There may be other factors to be involved. Is that a fair way of handling this? I think it's an honest way.
I would assume that's what this clinician did, and Mr. X became agitated and says he came to see you to get some answers.
But those
there
are
people who want.
But those are answers.
Yes,
Those are answers, though, and they say this is the best I can do interpretation, and if you want to say it's extreme, you can choose that as an alternative interpretation.
Yes, I think there are other. If this ambiguity is too painful to accept, and it certainly can be,
right.
Then I think other options are referral for a second opinion, which I think we don't resort to enough. I think this is a
good point.
If this were a situation where we were looking to make a diagnosis of a surgical lesion or a malignancy, it would be routine for someone to say, I want a second opinion.
That's pushing it off on the next guy. Had to do that.
It's a good strategy. It gives, if nothing else, it buys time for people
Right.
to adjust to what reality is. I think, as Ms. Gregg said, there's an educational process to diagnosis, and it may be that one is able to kind of say, well, maybe this other person. The other presumption we've made, actually, is that this is a grim diagnosis. The other possibility is that this is a 64-year-old who, I apologize to the salesman in the audience, but perhaps takes 3 or 4 highballs a night and his memory isn't quite as good as it used to be and isn't performing as well, and his company is threatening to downsize, and he's suddenly become a little anxious and forgetful and has decided he has Alzheimer's disease. I had a lady come to see me after she ran a red light. Her aunt had been diagnosed with Alzheimer's disease, and she came in and said, I must have Alzheimer's disease. I ran a red light.
I think most of the audience would be in that category.
We're going to have to wrap up this particular case here. One question from the audience, Dr. Mahler.
Was the APO done in a research lab or a certified clinical lab? Because if you're going to use information to give it to a patient, it really needs to be done in a certified clinical lab. And a related aspect of it was the PET scan that was done to see if is commercially available. Was the patient's insurance billed for that procedure?
All very, very good questions. I deliberately left some of this information out of there. With regard to the ApoE testing, to order that clinically, as Dr. Reed pointed out, is clinically available, one actually has to sign a release form. The physician ordering it has to sign a release form now saying that they certify that that patient actually has dementia, and they want to get that information only in a patient with a diagnosis. So that if it's done in a research laboratory, that safeguard is gone, and also the clinical quality assurance is not there. With the PET scan, was it ordered clinically? We'll never know. Any other comments from the panel?
The insurance company was billed for it, and it's a clinical procedure, and the patient is entitled to that result, just as he's entitled to the result of any clinical procedure.
Right. And in this particular situation, this was part of a consent form procedure here, so one would presume it was not ordered clinically. Any more comments from the panel before we move on?
Oh, I just had one. I was sitting here trying to think of how I can articulate this, and I'll do the best I can. I guess in working with families and individuals who are diagnosed with Alzheimer's disease or any other form of dementia, I think that there are lots of questions that families ask, particularly that there aren't really good answers to. And I think that, all the way from the beginning stages of why is my mother having memory problems to why is he angry with me? Why does he only lash out at me? Why can't they, or et cetera, et cetera. And I think in a lot of the questioning, this may be a little bit off, but from my perspective, a lot of the questions may not have good answers, or we may not be able to answer them appropriately or accurately, but a lot of it is providing families with reassurance in whatever way is possible. So.
Great, thank you. We'll move on to case number 2. Mrs. Y is a 73-year-old female with a 5-year history of dementia. She has been quite confused for the last year with a mini mental state exam score of 0. She's been living at home with her oldest daughter, but because of agitation, wandering, and psychosis, her children have been thinking about placing her in a nursing home. You've tried for several months to get Mrs. Y's children to consider Haldol for control of the patient's troublesome behaviors, but they have refused, saying that they don't want their mother to be, quote, drugged. Mrs. Y has been in excellent physical health except for her dementia. She suddenly is hospitalized with a high fever, worsening confusion, and agitation, and is diagnosed with bacterial pneumonia. The children say that they do not want any treatment for their mother. You explain to the children that this condition is curable and that their mother could still live many years, and with medication for the control of agitation, she could have an improved quality of life. They still remain adamant, saying that it is time for their mother to, quote, die with dignity. Mrs. Y never discussed her wishes for medical care with anyone. What do you do? I've asked Dr. Mosqueda to lead off the discussion on this case.
Well, I would get a second opinion. No. I think we don't know what type of dementia we're dealing with here. I'm going to assume it's something of a progressive nature, perhaps an Alzheimer's disease. There's the good old vitamin H of Haldol, or there's certainly other medicines that may be used, and I'm assuming that medical causes of this behavior have also been ruled out before throwing a neuroleptic center. To me, what this brings up are issues that are very related to communication, and I think oftentimes when we're dealing with bioethical issues, a lot of it does boil down to communication and understanding what somebody's values are. And I know as a clinician, sometimes I'm put in this sort of position where I don't meet my patients until they're in a fairly advanced dementia. And what I generally attempt to do is have this sort of conversation with family members about what we would do under different circumstances before this issue ever comes up. And indeed, this just happened in this past week with a fellow I take care of who has advanced Alzheimer's and has developed a pneumonia. And I know ahead of time, through discussions with the family, that we weren't going to treat. So we didn't have to rush in some sort of frantic emergency situation with me on the phone saying, should I put him on antibiotics? What should we do? And so obviously the nicest situation is when you know what to do ahead of time. What isn't mentioned in here, which I think is the core issue, is what do we think this patient would have wanted for herself? And that's the kind of discussion that I think a lot of us generally have with family members is what was important to your mom? What kinds of things did she like? What did she value? And what do you think, what did personhood mean to her? What do you think she would want in terms of her medical care? So the question isn't, I don't know if they want her to die with dignity because she has some huge fortune that they're going to inherit, or if they want her to die with dignity because this is truly her version of death with dignity. And I think that's what I would be trying to find out.
Let me take this opportunity to make your life more difficult here. In fact, one of the bits of information I left out of here is the legal status of the patient and the family. That is, let's say that nobody really has any kind of power of attorney for the purpose of medical decision making, and the patient herself left no advance directives as to what she wanted to do. I agree with your perspective that it's important to ask the children, what do you think your mother would have wanted? Even though we ask that question commonly, nobody really has a legal standing in this situation as described to make that kind of decision. How do we wrestle with this?
Well, maybe I shouldn't say this out loud, but I just don't worry that much about the legal standing. If we sit down and there's no reason to believe that anything unethical is going on, that there aren't any evil motives, and I don't hire private investigators to find out. But if we don't have that sort of a sense, I usually sit down and have a discussion with people. I don't necessarily ask that question anymore. I used to. What would your mother have wanted under these circumstances? That's awfully hard on people. But I usually just start out by saying, tell me about your mom, and trying to understand her a little bit more from the family's description. And I don't get that hung up on worrying about the legal status, as long as we're all seem to be moving in a direction that, to the best of my knowledge, is in keeping with her wishes. I'm generally satisfied.
Okay. Other members of the panel? Let me ask Sheila, if I could, in working with a family like this, clearly the kids have very strong opinions on what they would like to do. How would you go about working with them and perhaps seeing if they're certain or seeing what motivates them?
Well, actually, I had lots of thoughts about this case. I think it really struck me for a variety of different reasons. I don't know if I'll be able to answer your question directly, but just in my comments about this, what struck me was this is a family who was they were ready to move and make a decision. And I think so often in dealing with families, it's such a struggle to make any decision, to make these choices. And so it struck me, why, again, kind of to the level of motivation, why is this family making this big decision that's usually the families that we work with are the exact opposite. They want everything. A person can be in bed and contracted, and they want everything. And identify quality of life as the fact that they still have their mother or father still living, and they visit them, and that's kind of quality of life. But as I was thinking about this and trying to make sense, I don't want to say I would question their motivation. Some of the things I thought of was, well, gee, of course the medical doctor would have a relationship with them and understand where they're coming from. Perhaps there are connections in the community that I could contact who know this family and could help me understand a little bit more about their decision. But also in part of the packets that we got today in order to prepare was an article called Dementia, Discourse, Ethics, and Well-Being. It's a chapter from a book. And one of the lines that struck me most was the author says, one caregiver said that it would be better to speak of the quality of lives, since the person affected with Alzheimer's disease, for example, is not an individual but a loved one in an essential relationship with a spouse or with a family. And so it kind of got me thinking about the quality of life of the children and of the family and what this means to them. And if they aren't, if they aren't the right ones to ask, particularly a daughter who's caring 24 hours a day for a mother, then really who is the right one to ask what should be done? And it's kind of within that context. Those are some of my thoughts on the case.
Thank you. Thank you very much. Please, Dr. Reed.
I wanted to see if Ms. Gregg was going to comment on this.
I have very little to say on this one. It just struck me that
Pull the mic.
Just struck me that the family was very quickly in accord, which doesn't seem quite fitting. I don't know why, but it just didn't strike me as being very true to what I've experienced. Our family, when we reached a decision, like putting my husband in a nursing home, we went through several family discussions. Not all of us agreed all the time on the things to do. We ultimately came to an agreement, but it's very unusual for everybody on such a serious matter to just go lockstep behind each other.
I think the thing that I find most difficult about the case is that this really is a curable illness in a patient who has been in very good physical health, who could live for a number of years more, albeit with very poor mental status. Any thoughts about that situation?
I've heard frequently that people with dementia very often are in very good health and very often enjoy good physical health. So I think it would be very hard for me to decide against a treatment for something like this. In fact, I couldn't.
I think what you're wrestling with is motivation. What is motivating these children to make this decision? And whether or not this is, we don't want to be bothered taking care of her, whether this is the attitude that's back of it, and as you were saying, they were tired of the caregiver was tired of the burdens placed upon them, or whether this is something that perhaps they had discussed a long time ago and had reached a consensus. We're back to this mysterious quality of life phrase that has to be interpreted in terms of what I as an individual consider to be my quality of life, my autonomy to make that decision. And apparently this hasn't been done, or perhaps it was done. What we don't know is what lies back of it. And your point on taking a narrative approach, the narrative ethic, whereby discussion and dialogue, you begin to perceive something of the nature of the person who's involved here and the nature of the family, might provide the guidelines that lie behind this kind of a decision.
Great, thank you. Dr. Reed?
I'm not sure if I have anything new to say. I think my experience is that these are more conflicted decisions than is suggested in this tableau. And it does, accepting this as true, suggest that there was some kind of it would be odd to me that a physician wasn't involved in that coalescence of opinion. It would be odd to me that the physician would be outside of that. I think there are parts of this setting that sometimes are more difficult. It is not uncommon for a patient to be cared for in one setting, and when an illness intrudes, to go to a hospital where people that have never known this person before are involved in care. And that's much more difficult, I think, for a hospital doctor not to have any appreciation for this dynamic that's reviewed here for months of discussion and concern about well-being. There is certainly no suggestion in this anecdote that raises issues of, at least prior to this time, of abuse or neglect or bad intent, bad motivation on the part of this family. I think there is some irreducible legal ambiguity in this case, and I certainly wouldn't take issue with Dr. Mosqueda's approach. I think that's the strong way to go. There are times where the decline, assuming a progressive illness, and in that decline, family members who are not involved day to day, as it suggests these people are, may not be aware of and may have different reactions to this situation, and I think we've been called in horror by someone. You mean you're not going to, or you are going to, or something. And those kinds of conflicts in families, again, are very difficult if there hasn't been, they're difficult anyway, but they're more difficult if there is not some decision about who's making decisions, as we talked about earlier. I don't know if those are helpful comments or not.
Those are helpful, thank you.
I mean, there's one more dilemma that I think is posed here, which hasn't been mentioned today, but in this jurisdiction, laws against physician-assisted suicide have been abrogated by court order. That's on hold at the moment, but this is a very active issue, and I think would add another layer of difficulty if that kind of issue were to be brought into a scenario.
I will invite anybody from the panel to comment on assisted suicide if they like.
I don't think this is really a case of assisted suicide. This is a pattern of medical neglect or abandonment of treatment, no heroic means. However, I am convinced that with the trend that we're seeing in our society, Northwest Australia has already legalized assisted suicide. It's practically legal in Holland. The decisions here that are being made on the West Coast of the 9 western states, and so on, the law in Oregon that was passed and is being held off by a judge, all of these things indicate that we're going to be into assisted suicide very shortly. And I think that's going to change the complexion of these kind of questions, and it'll be a completely different issue, probably primarily for people who are terminally ill and who have requested aid in dying. But whether that can be expanded to family getting involved and so on. The autonomy of the patient in everything that I've read so far has been the key. Not family's wishes, not what the doctor talking with the family. It's what the patient says, this is what I want. And of course, the other aspect of this is that we already have something of this in effect with the increasing of the morphine drip causing death as a side effect, even though that's recognized as what's going to happen because of this so-called control of pain. We're into a very complex situation with the assisted suicide.
I think it is very problematic, and certainly one can conceive of this kind of patient being terminally ill, even though the terminal illness may take many years to run its course. Invariably in this kind of situation, certainly when the patient's more advanced.
Generally, terminally ill is within 6 months anticipated in everything I've read so far.
Right, I agree with you, but I think that there's certainly those who argue for extending it to anybody with a diagnosed illness that would end up resulting in their death.
And in Holland, they're now taking mental pain as part of a diagnosis for instance, the homosexual who decided he did not want to go through the various stages of dying from Kaposi sarcoma or whatever lay ahead of him, chose a time when he wanted to die, insisted on this, and was helped to die. And he was in perfect health.
Very, very difficult issue. Thank you for your comments. We'll move on now to case 3. Mr. Z is a 76-year-old male who has been in your care for approximately 6 months. He was referred to you by his family for the evaluation of confusion, and during the time you have seen him, he has become increasingly confused. You believe he may be demented, but he has refused to give any have any systematic testing or evaluation. He tells you that his family wants to get a hold of his considerable fortune, and he wants to control his money himself. Mr. Z's son calls you to report that his father is losing large sums of money through carelessness and poor judgment. He also reports that his father has been driving erratically and almost has been in several serious accidents. Mr. Z refuses to see any other health care provider, and the son says that you are the only person who can provide an affidavit to help them get a conservatorship. What do you do? This case poses a number of difficulties, ranging from legal requirements for reporting, non-legal requirements to maintain a patient or public safety, as well as difficult issues within a family in terms of who to believe. I have asked Dr. LaRue to start the discussion on this case.
I wish you hadn't, but that's...
That seems to be a common sense.
I know,
on the panel today.
It's easier to chime in after somebody has laid the issues out. The first thing, of course, is public safety. I would be very concerned about the driving pattern, and I think steps can be taken to either limit the ability to drive, refusal to have his driver's license extended, and so on. I think in terms of the man's safety, my safety if I'm on the road when he's on the road, and public safety, something has to be taken seriously, and somebody has to do something there. And I think the DMV would be the people to get in touch with and talk with them. The matter of the large sums of money, we're getting so many reports now of financial abuse by people taking advantage, particularly of elderly people, and particularly of people who might be on the edge of some form of dementia, that I would take this seriously. On the other hand, the first thing that Mr. Z's son wants to report is that his father is losing large sums of money, and the father says, yeah, and that's what they're after. So again, we're into balancing the evidence. As a clinician, it is obvious that this person is in some form of dementia. How serious this is, we can't tell. But I would think here that we need financial consultant. I would get in touch with his bank and find out what they're saying. If he's giving $1,000 to, what was this man's name that took $900,000 from the woman, this Whitaker, whatever the minister's name was. If he's giving money to that sort of an organization, some cultic group, I'd like to know this. The other thing is we have provisions now by which financial advisement can be taken, and he can be put under a conservatorship for financial control, and I would advise that. Again, and I would be willing to write a statement to say that something has to be done to as a conservator, to appoint a conservator to take care of this.
Well, I think that if we're certain the information that the son is providing is true, some of those steps would be highly warranted. Let's say that we're not sure the information is true. Let's say that you're not sure that the son isn't after the money and isn't making some things up. How would that influence your actions?
Again, if you knew where the bank was, you could also check with the bank person, telling them what the concern is, and whether or not they would release that information to you or not would be a matter of debate, and they might not. But this is a matter of concern that I would raise with Mr. Z himself. Ask him if this is true, and if he says yes, I'm giving money to this group and that group and so on because they're nice people and they've come to my door or whatever it happens to be, then I would be concerned. The driving pattern, though, is one that really frightens me, because he could do some real damage on our freeways and on our highways. And at this point, again, I would have somebody check. And I don't know how I would do this through the DMV. I don't know the process, but I'm sure that something could be done.
Okay. Ms. Gregg.
I did have some experience with the DMV, and
Besides waiting in line, I take it.
that's one of the hardest things for an Alzheimer's patient to give up for the keys to the car, in our case at least. I don't see how this patient, anyone could take any steps without a diagnosis, and if he's refusing diagnosis, in our case, the diagnosis was made and the doctor was able to contact the DMV, and when my husband called to renew his driver's license, the DMV made arrangements to talk to him over the telephone, asked him questions on the telephone. Of course, he was confused. He went into the DMV and was talked into getting an identification card to replace his driver's license. It wasn't easy, but the only way that we could do that was after diagnosis was made. So if this man is refusing diagnosis, I don't think there is anything that can be done.
But you do have here the concern that he may be demented, and
But that's not a diagnosis.
It is in a sense, but it's an area that needs to be investigated. I think this is a very, very difficult case because
There are two things, Alzheimer's being one,
Right.
or dementia being one,
Right.
and I think epilepsy the other. The DMV has to take action on it.
Well, let me throw this to the physicians on the panel for a moment. You have a patient who, whenever you ask a question, try to determine how much memory impairment there may be, how confused they may be, they say, I don't want to answer your questions. And they just want to talk about what they want to talk about. So it's very difficult for you to assess the presence or absence of dementia. They refuse formal testing. How do you handle the reporting requirements, reporting options?
Reporting to whom?
Well, for instance, starting with reporting to the DMV. That is, when the diagnosis of dementia has been established, one is in fact obligated to report to the DMV.
Right. Well, first of all, anybody can report anybody to the DMV.
That's true.
So, I mean, if you have a concern about driving, and somebody can be reported, you don't have to have the doctor do it. If I'm bumping into somebody who refuses to answer questions, there's a reason that people refuse to answer questions, and I don't know that at that point if there's a psychiatric illness going on, if they're paranoid, or if there's a dementia going on and they're unable to answer questions, and that's what I need to start sorting through. If we have somebody who refuses to answer questions despite understanding the consequences, or despite explaining the consequences, they might not even be able to comprehend what the consequences are. And to me, this just is indicating more and more some illness, although I don't know if we're dealing with a dementia or, as I said, some sort of psychiatric problem. So then I would call Dr. Reed.
jeez.
And Dr. Reed's opinion would be?
I can see the trap
I
closed.
think I heard that one. A couple of things. First of all, if I can remind people of the discussion from Ms. Scott earlier today about the thrust of the criteria for conservatorship, is that the grounds for conservatorship, again, are not diagnosis-based, but based on the demonstration of mental deficits which cause impairment in function. And so the crucial element is, in fact, the clinical evaluation. And one may wish to have specific kinds of testing to elucidate the cause of mental impairments, whether it is Alzheimer's disease or stroke or not those things or whatever. But the demonstration of deficits is clinical. In this event, if it were I who had been seeing a patient for 6 months and had presumably seen this person several times, I think I would have my own impression as to whether there were deficits or not. I don't think that an experienced clinician would see someone over this period of time and there may not be confidence about what caused it, but I think the crucial thing is when the son calls, assuming that it's calling me, am I also concerned? I also assume that I have a line of communication, again, open with the family because he was referred by the family. The more painful.
Good point.
The real dilemma would be if this person, if this were the gentleman in the first case who came, and if he came by himself and then forbade me to call him, explicitly forbade me to call someone, that's a more difficult dilemma. And I think Dr. LaRue put his finger on the crucial part, which is the dangerousness of it. A more trivial case, I saw two people in 1 week who had spent, interestingly, $30,000 each responding to mail order lotteries.
Oh dear.
And in one case, the consultation was prompted when the pile of lottery-induced mail had spread from the dining room. The family conceded the dining room to this person. When it spread beyond the dining room, they said, this is too much.
How big is the dining room?
Unfortunately, they ended up running. The $30,000 wasn't, in this case, crippling, an enviable position to be in. But money is a big issue, and I can imagine myself writing a letter to support. I think the crucial thing is that there obviously needs to be an attorney involved in this account.
Yeah.
If there is reason to think that there is more immediate danger to somebody, the possibility of involuntary psychiatric hospitalization, during which one, the criteria for that again are presumptive evidence of a mental disorder, which may or may not be present here, grave disability, and an unwillingness to seek treatment. So when this person could be assessed for that, and at that hospitalization, presumably a better answer could be given. And that answer could be obtained prior to the labor with which we've already heard today it can take to get formal conservatorship.
Dr. Muscat.
And I like in cases like this, I have found private conservatorship to be a very helpful option, because it can take the son out of the loop and he doesn't have to worry about being accused anymore. And I've been through this with families where there really was very fine motivation on the part of the children if they were being accused. And they were going nuts. They said, here I am trying to do everything, handle their money, and et cetera, and they do nothing but accuse me of stealing their money. And then we'll bring up the option of private conservatorship. Just get out of the loop. You have to pay for it, but then you don't have to be under that sort of pressure anymore. And if you're really sincerely just looking out for their best interest, it's can be a very good alternative.
I suppose that's really part of the question. That is, how can you be certain that the family is looking for the patient's best interests? Let me draw in Ms. Moore here because of her probably frequent situation being caught between patients and family.
Mm-hmm. Yeah, I was struck, again, this is another case that I was struck by the fact that the last line is, and the son is seeking conservatorship. And again, that's usually a word that families don't bring into the picture until it's usually brought, we're usually the ones that bring it up. And so I was thinking about the issue of conservatorship, and I was thinking this is either a son, one who, as we say, gets it, who gets the whole picture and realizes that this is a situation that, one, places his father at risk of being victimized financially, and then also places him at risk in terms of his safety because he's driving. Or this is a son who, again, they have to question his motives. And I always hate having to question people's motives, but I always think that as a social worker on a multidisciplinary team, that's part of my job, is to look for the red flags. And so I was concerned about that. And another issue that I was thinking about was of Mr. Z, that also as a social worker, we think in terms of self-determination, of having him have the capability to make decisions for himself and be involved as long as possible, which I think is always tricky when you have someone who's confused, because you can't always involve them like you'd like to. And the second point is his integrity, that just because he's confused doesn't necessarily mean that he's not telling us that there's something that we need to be aware of. And I often think of the example of, in the assessment, part of the assessment is asking, gee, is your parent or spouse, paranoid or confused, and oftentimes families will say, yeah, well, they think that the sister's taking it, and in fact, the sister did come in and take this, 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 and this, and so they have every right to be confused, or patients who live in retirement homes or board and cares who are being victimized by staff and are accurately reporting, so I'd be concerned about that. And I agree with Dr. Mosqueda about having a third party introduced into the situation. I think it does take a lot off of the family and the patient, and I think ultimately would think of conservatorship, but I was thinking initially as a kind of a point of intervention would be, since we don't know why he's having the memory problems and still up in the air exactly how, is this a short-term problem or is this a long-term problem, that maybe we could find someone in the family whom he does trust who could have, a power of attorney or something that could be revoked at some point. At least so that initially his finances are safe, and then with the ultimate goal, more of a long-term goal of appointing a third-party conservatorship.
Okay, great, thank you. Yes, Dr. LaRue.
One of the things I'm going back to, and this is the statement of Mr. Z's son, that his father is losing large sums of money through carelessness and poor judgment. Somehow the son has access to information, apparently. And I go back again to the role that I've talked with bank presidents and in terms of their concern for the well-being of their clients. And there have been case after case where they have felt that large sums of money are being taken out by someone who may have some problems in judgment, and they have tried to do everything in their power to restrict that activity. And I think it would not be amiss for the son or for the clinician to phone the bank and ask them to look into this and to exercise whatever controls they could. Because, again, we're back to the rip-off that takes place so easily in the lives of some people.
Dr. Reed.
I have to say Dr. LaRue is more optimistic about the goodwill of banks than I am. My understanding is the banking industry, in fact, there's specific legislation exempting banks from any responsibility in this
That's
situation.
true.
And I'm familiar with more than one case where they specifically refused, certainly to give information, but when it was clear there were patterns of misconduct, and one case went on for 12 years.
Oh my.
So I feel like a bad guy saying it.
Well, I feel like a good guy, you see. So.
Okay. At this point, we have 10 minutes left before the close of the session. We have 15 minutes left before the close of the session? No, we have 10 minutes left before the close of the session. And I would like to open the floor to questions. Oh, yes.
I'd be interested in knowing from the physicians what their responses to the spouse having physicians go to the court for some kind of release from treating the authorization, particularly in that second case where there was the treatable disease and decision process. And that whole feeling with putting yourselves in any kind of liability or jeopardy.
Just let me repeat the question for the audience just for a second. Please tell me if I get it right. The question is, what is the responsibility or liability of a physician going into court trying to get treatment for a patient that the family does not want? Is that? Or to back yourself up for not treating a patient. Okay. Great. Please.
I document my discussions with people, and my discussions, as I mentioned earlier, generally try to get at our best guess as to what was important to this person when she was able to discuss things. I guess the other thing to think about is who's going to come back and sue me if I do the sincerely best job I can. I mean, there's the saying that I do believe that anybody can sue you for anything at any time, and everybody does. And so there's always the risk. But my primary responsibility is to do right by my patient and to find out what that is to the best of my ability, and then I document it. And I document it very carefully. I don't take this lightly by any means. I put it down a fairly extensive note about my discussion and what conclusion we came to and what led to that conclusion. And then I write the order of no antibiotics or whatever it may be, feeling that I've sort of done the best I can.
But how do you handle it if you were not in agreement with the family who had sold the treatment?
If I feel that if I'm not in agreement with the family, then there's a few ways to go. If the family is asking me to do something that would violate my own morals or my own ethics, yet is in keeping, but yet we don't think there's any evil, terrible intent going on, then I have a responsibility to get another physician involved, perhaps transfer care. This might be a very good time to get the ethics committee involved. I think this is a good use of the ethics committee to help out. But if I think that there's any evil intent, then I have a responsibility to get the law involved too and become really a protector, if you will, for that patient.
Dr. Reed.
I think there are several options in uncertainty, and I think there's certainly situations and physicians where the physician in something like case 2 would feel an obligation to treat. And I think the procedure was discussed some this morning. The resort is to go to court, and the court then has the ultimate decision as to who will make decisions and can, of course, part of that is what the decision should be. And what we learned this morning was that if the court decides that refusal of care was properly made, that then the physician is then absolved from the consequences of not treating that patient when that treatment isn't ordered.
Okay. Thank you. Ms. Gria.
When a person is well, when they say all legal papers, like the marriage certificates and the certificate that brought your home and everything are legal in court, why can't they make a paper out when they're well, how they want their life to be handled when they get critical illness? Is there a problem with that?
The question was, is there a problem with, excuse me, a person when they're well making out a document saying how they want their life to be handled in the advanced stage of dementia?
No.
Well, one problem is that most people don't do it. Most people don't like to think about these things. And so most people don't pre-decide. What I find as a clinician is difficult is that applying someone's expressed wishes to the situation at hand is not always clear. And I think this, even in a simple event, simple in a decision-making sense, whether if someone has a cardiac arrest, do I initiate resuscitation, even that has complexities to it. And for other kinds of procedures, it can be a little bit tricky. But it can be extraordinarily helpful in two ways. One is it may be very applicable, and in this case, there may have been someone that, my mother said this. If I get to this point, I don't want anything done. It may also be helpful in that the tenor of that wish, even if it's not specifically applicable to the situation, may be very helpful to the person that has durable power of attorney or who becomes conservator.
That's really what you're talking about,
Yeah.
is a durable power of attorney. You're talking about an advanced directive, which we really
Right.
encourage people to fill out. So
That's it.
that's why there is no problem. I mean, we encourage people to fill out advanced directives, especially through the durable power of attorney for health care.
And also for finances.
And
One trick is having an advanced directive at hand when you want it. People don't remember to bring the, they fall unconscious and they don't remember to put it in their pocket before they fall over.
Do it on their check.
Let me invite Ms. Gregg to comment on any experience or thoughts you may have had in this area.
We've had a durable power of attorney between us for quite some years. My husband is an attorney, and he felt this was very important. It's something that we had discussed when he was perfectly well. Both of us agreed. His mother had Alzheimer's. We both agreed that we didn't want to be left in this condition very long. We wouldn't want any extreme measures kept to keep us alive. Right now, when I go to see him, I wonder just how much of that he would agree with now, because his perception of the value of life now has been lowered quite a bit. He's not demanding it as much. He's content where he is. He's content with his life the way it is, as far as I can tell, with his life at the present. And so, whether he would say that his quality of life now is way below what he can possibly tolerate, I don't think he would. I think he can tolerate the quality of life he has right now. So I wouldn't feel that this was a time when I could say, we agreed to this.
How do you feel about visiting?
Beg pardon?
How do you feel about visiting?
The question was, how do you feel about visiting him?
How do I feel about visiting him? We're having more quality time now than we did when he was at home. Because I can visit him. We have good times together. I take him out for lunch. We get back on some good subjects and remembering trips we've taken, that sort of thing. When he was at home, I was stressed out so much of the time that sometimes our life didn't have a lot of quality. And even though he was in daycare several days a week, the night duty was pretty hard on me. I was getting to the edge before I knew it. And so I feel pretty good about visiting him now.
That's great.
Beg pardon?
Very glad to see him.
We have
Yes,
time.
and he's glad to see me. He doesn't always call me by the right name, but he's glad to see me.
We have time for one more question over here, yes.
We've been discussing making moral and ethical decisions, including the team, social work team, and family work together with moral and ethical issues. Nowhere in the discussion does anyone mention bringing in spiritual leaders, pastors, or rabbis who may have additional knowledge about that person's wishes, because they talk about it in the confession, but they talk about it just in the course of having religious discussion. And I haven't heard anybody on the panel discuss that, and I'm curious to hear what you say.
A very, very good point. What is the role of spiritual counselors or leaders in this kind of decision-making process? Let me ask for very brief comments in the 1 minute we have remaining.
To me, that's something that I talk to families about. For some families, it's very important, and for others, it isn't. So that, again, is very individualized, and I think always an available option for family members for that person to be included. I'll just tell you very briefly about an extraordinary home visit I made just this morning. When I was called in because this woman became very ill and nobody knew what was going on, and it was a home that literally was converted, the living room, and was converted into a chapel. And they were, I don't know if they're truly ordained nuns, but everybody in nun clothes were living there. And this woman had a stroke, and she was the mother superior in that. So I really had to be guided by them, even to how much I could touch her, how much I could undress her. And so all of our, and she certainly doesn't want to go to the hospital or have blood tests or intravenous or, so everything that I'm going to do with my treatment when I go back and see her tomorrow in her home is going to be completely guided by the spiritual aspect of their life. This is an extreme example, but I think...
Whether they're positive or negative.
Yeah, that's their call.
Yeah, right.
I'm afraid we have to draw this session to a close. Thank you for your comment. And I want to thank...
God, we're good, aren't we?
Oh, yeah.
Interestingly enough, it's an irony, but turns out that Mr. X, Mrs. Y, and Mr. Z all were in my office last year. And the kinds of things that went on in the last panel are just the kinds of decisions and issues and questions that we have to deal with and have had to deal with over the last couple of years. And just like many of the panelists, I just referred them to Steve Reed. As in, if it's broken, it's not my fault, call Steve. I do have to tell you one funny story about driving license, I was a caretaker for my mother-in-law who passed away, and we did have an interesting question about a durable power of attorney, a living will, which I won't get into, but at one point she was hitting every object on the road. Her car had dents from here to there, and you would point them out to her, and she would sort of ignore them. My brother-in-law and my wife were sort of arguing over who should tell the DMV, and they pointed to me, and I said, no, I'm the son-in-law. It's up to one of you two. And my brother-in-law did turn her into the DMV, and she got one of those little conditional licenses. And at her funeral, he came up to me and he said, Mom was a really good person, so she's probably in heaven. You think God's going to tell her the truth? Because she always said, I don't understand how I got turned in, So what I want to do today is to speak to you from my perspective as not as a medical expert or a researcher or a caregiver or a care provider. I'm a public policy specialist, and my job, if I do it well, is to balance competing interests and try to squeeze the most care out of the fewest dollars, and it isn't easy to do. The times are against us, and in this age of distrust and cynicism, something isn't real, I think, unless it's happening to me. And certainly, we ought not to pay for anything that isn't real. And so, consequently, if I don't have something wrong in my family, or I don't have it personally, I don't want to pay for it. And you all know what this ends up looking like when you're dealing with issues like Alzheimer's and dementia, which are not the problems of the family, no matter what people will tell you, but the problems of the society. But this is an era where politicians blithely mouth platitudes about personal responsibility, which means if something happens to you, it's probably your fault. And in any case, it's not my responsibility to take care of you. This attitude pervades every facet of the public policy disclosure, discussion, and discourse. You hear words like utilization review and managed care and cost-benefit analysis and risk management. And these are terms that are really very different and foreign to the people who are on the front lines, like family caregivers and medical staffs and nurses and physicians who deal with people with dementia. We face some demographic and social and economic time bombs, and hiding from them aren't going to make them any easier. It seems to me that we need to be able to face up to these kinds of questions as soon as possible. It's my job, as unfortunate as it may be, to be the interface between people such as yourselves in the field and the decision makers in Sacramento. It's my job to harangue my bosses about the horrendous needs in the community, and it's my job in return to come to tell you that there's not enough resources to serve everyone who has needs all the time in every place. Competing interests, and it can be a painful and even fatal disease. A. Allen Post, who is a former legislative analyst and a terrific artist, by the way, once told me that, he said to me, Paul, if you find that you're in a very difficult debate and both sides are shooting equally hard at you, you're probably doing the right thing. That probably explains why people in Washington and Sacramento are so often perceived as not doing the right thing. And it's self-preservation pays off in many cases. But what I'd like to do today is to describe some of the demographic trends that we see, basically kind of a big picture, and then talk a little bit about some of the dilemmas and questions we face in public policy, and hopefully talk about a few solutions. Now, a lot of these things, in a way, this will be a recapitulation of things that you've heard today, because I know that some of the bills we worked on have been talked about in this session, and certainly some of the issues that I'm going to review here were dealt with in the last session. And so I wasn't here for the complete conference, but it looks like from your agenda, a lot of these issues have been dealt with. I want to point out these issues a little bit to just relieve your fear that we don't up in Sacramento know about these things. It's sort of the case that it helps, I think, a lot of times when decisions are made in Sacramento and bills are passed and signed into law, if people know that we have at least considered all the different perspectives, even if it's a perspective that you don't personally agree with. Some of the demographic challenges that, and I've just picked a lot of statistics out of reports I've read recently in hearings. One of the good things about being in Sacramento is that you don't have to be smart yourself. You just have to have a whole bunch of people who are smart around you, and you just call them in for hearings, and then you steal everything they tell you. So it's easy for me. I just steal from people. 2 reports came out last year that I want to mention that indicated that between 42 and 48% of all people over 85 have some degree of Alzheimer's or related dementia. Another statistic that Dr. Katzman gave us at our last hearing on Alzheimer's in February was that about every 5 years of chronological age, the number of persons with dementia doubles. A third is that we can cut the incidence in half by delaying the Alzheimer's by 5 years because it's so age sensitive. Early onset genetic markers are more dominant, and so we have sort of an ethical problem here to face in the form of testing because it's more predictive than late onset, the APOE4 testing. Head injury interaction with people with the APOE4 allele is a factor. It turns out that there's some research now that shows that head injury is becoming an increasing factor. And I'm dealing this year with a bill on traumatic brain injury, and I think that the more I deal with this issue, the more I think it's a contributing factor. The interaction of cognitive functioning and the onset of Alzheimer's is also an interesting fact, and you probably have seen some of the studies about a lot of the PET scans in terms of looking at what cognitive functioning goes on in various kinds of fields, and that people who have fields like mathematicians and musicians who use a lot of neuron firing patterns happen to have delayed onset in some cases, and so that has an interesting sort of consequence, it seems to me. Another fact is that, of course, Dr. Wendy Max recently has redone a study and shows that Alzheimer's costs about $48,000 a year in direct and indirect costs. Read a study last year where women who are between the ages of 40 and 55, which includes most of the baby boomers, if they live to be 65, will have a median age at death of 93. So there'll be a significant number of people who will be in the baby boomers who will be in the prime Alzheimer's window for a lot longer than we've ever had to deal with before. What the implications are for the number of people who will have Alzheimer's by the year 2020 is pretty staggering when you actually take your calculator out and look at it. Of course, you know, that is if we don't find a cure and at least treatment for Alzheimer's. Last year there was a GAO study that showed that people over 80 have on average a lower annual health care cost than people between 65 and 80. They showed that only people over 80, actually only 4% die from cancer, and they have a quicker death on average. And so this leads into this whole question of the new health policy buzz on compressed morbidity, and if that isn't the way we should be heading, that you live longer and die quicker, I think is the way people explain compressed morbidity. And finally, I think it's the fact that we need to take care of looking at statistics about traumatic brain injury with new recreational devices, new speed, faster speed limit, more risk-taking, more drugs and alcohol in the society. I think it's a fact that we're going to have more and more traumatic brain injury to deal with. These are just a few of the demographic trends that are out there, and I think that we need to look at. One of the things that we talked about in the panel before has to do with testing, and I want to talk a little bit about the testing in the largest possible sense, particularly a distinction perhaps that we should make between testing, which is testing genetic material alleles that are either predictive on the one hand or causative on the other. And I think that probably on a policy basis makes a big difference. I want to quote Dr. William Jagast, who was also testifying at our hearing on Alzheimer's in February, and he brought up this point. He said, at the risk of sounding humorous about what's not a humorous subject at all, this kind of new science does give us good news and bad news at the same time. The good news, of course, is that by understanding the new genes that are involved in Alzheimer's disease, we may be able to understand the mechanisms of the disease and develop ways to treat the disease, to actually cure the disease. But the bad news, of course, is it provides us, we are in a phase now, where we have a lot of information, and we can't necessarily do anything about it, and that is really a big price in many respects. It's a price in terms of personal decisions, personal anxieties that it creates for people. It creates problems with issues of discrimination, insurance, and health care. It actually creates diagnostic issues that I think I just want to address for the moment. He goes on to talk about some of the diagnostic issues. So I bring up the issue to you, and this is something, of course, we've talked about a lot in the last year or two in the legislature about testing. Whose right is it to get tested? Is it a clinical test, or is it who's doing the test? Is it a lab? Is it something that comes from the request of a person, or is it something that is a request of a physician? How should we use them? Should we test the general population? Should we test families only who have Alzheimer's families? Should we test just early onset people and not people perhaps with an ApoE4? Is it the case that we just try to come up with tests only for causative and not for risk factors? What do we do with the tests? I mean, the upside, of course, and you may have read the story about, it was in, I think it was in the USA Today a couple weeks ago, it might have been in the LA Times, about a gentleman who got into this debate about having a test and having his family test, and he talked about why he did that. And, the whole question of financial planning and, I'll live my life differently if I have the test. On the other hand, even with the APO4 allele, according to Dr. Katzman's examination, you only have a 90% chance of actually getting the disease. So the question I have is, even at that level, is that test relevant? And of course, the big question that we have as public policy makers is, what do you do with insurance companies who want to know about that test? And how do you risk manage this thing? If you don't risk manage the disease, Alzheimer's disease, in its fullest form, including long-term care across the whole population, then these tests can become really problematic as to how you use them and who has rights to get that test results. Also, we have questions about PET scan as well as MRI, and if we can do PET scan testing in a way that becomes more predictive, should we? And at what point should those tests be required or requested or even made available to people? We could talk about of course, drug treatments and interventions, things that are not, that are sort of in a hazy view of possibly being effective but not necessarily determinative in either curing or even delaying the onset. At the same hearing in February, Dr. Carl Kottman suggested that there are some new studies that suggest antioxidants may be proved to be an alternative. So if that proved to be true, what would we do? Do you induce people to take antioxidants? I mean, I don't know the answers to these questions, but I think some of these need to be posed. One of the questions that came up after our Alzheimer's hearing in February, which was televised around the state, I got a call from a doctor who was actually from Holland, where we talked a little bit about before. We're legalized. There is a sort of physician-assisted suicide has some legalization features to it, and this doctor was really excoriating us for even suggesting that we should do anything to extend the life of somebody who has Alzheimer's, and it sort of brought me up short, that somebody would hear this wonderful testimony, talk about all these advances, and the conclusion that he draws is this is a bad thing to do. But I think that it does hit upon, for me, a sensitive area, which is that there's a lot of legislators up in that state capitol who don't have firsthand knowledge of Alzheimer's or dementia, and I'm not sure what their sensitivities are. When you start talking about cost effectiveness, I think that some of these issues come into play directly or indirectly, and I think we just need to be aware of that. We need to be able to do some education to make sure that kind of decision making isn't made in the absence of real data. And then the question, of course, is should we use our scarce resources in what way and at what point? Should we use them for research only? Should we use them to develop programs for people who have Alzheimer's? Should we use our resources to try to develop delayed mechanisms? In what way should the legislature decide to put their resources to work? We should, of course, inevitably it's going to lead to 2 or 3 different kinds of discussions. One has to do with assisted suicide. I was just on a panel a couple of weeks ago at Sac State with Derek Humphrey, who is the founder of the Hemlock Society, some physicians and some religious folks. And we had a really stimulating discussion about the question of physician-assisted suicide and death with dignity and all those things that are entailed. And I just think that that's inevitable, that those questions are going to be asked more and more in the coming days. And I also think that the next inevitable question that's going to be facing the legislature very soon is going to be the question of genetic engineering. If we end up finding out that there are, in fact, causative genetic linkages, what is the efficacy of developing or prohibiting genetic engineering, and how soon, when do you do that? And of course, that gets into the whole questions that about Huntington's disease and fetal tissue implants. Now, I'm trying to lay these things out not to, I think, to make anyone feel real anxious or as in any way negative or depressed. I mean, they are what they are, and these are issues that we have to deal with every day. What we think we can do, though, is to come up with some things. What is it that we think we can offer the state of California and people who have Alzheimer's and their family members and people in the caregiving fields as well as care providers? The first thing I think we need to be able to have is this infrastructure for people with dementia and any other kind of mental disability and be able to make distinctions between things that are severe mental disabilities, for example, an LPS kind of conservatorship, and what ought to be in an organic brain syndrome, in my judgment, a probate conservatorship issue. So we need to be able to have better tools, legal tools available to us. And toward that end, of course, last year we developed SB 730 along with help of Dr. Reed, Dr. Spar, and Mark Hankin, attorney, and Alice Mead, who's the chief attorney for the CMA, to try to come up with a way in which we could make decisions about capacity that aren't based upon diagnosis or not diagnosis-driven, as Steve said, based more upon deficits in mental functions and impairments that are causing a person not to understand and appreciate the nature and outcomes of their decision-making. It seems to us, I think that SB 730 was not a perfect bill, and it certainly will be needing to be updated as we go along. But I think that it's a step in the right direction. I stand fully behind it, and I think it's long overdue that we made this change. It may be the case that there are going to be more difficult decisions made in probate courts, but so be it. I think that that SB 730 certainly levels the playing field, makes capacity questions more understandable, not only to attorneys, but to judges and to family members. One of the things that is stunning to me, if it isn't to you, and if you haven't dealt with probate court, you ought to know that probate judges rotate in and out, in most cases, on a 2-year cycle. And they're not particularly well trained in probate issues. And in many rural communities, they're not at all probate judges. So what happens is they end up in an unenviable position of having to trust any doctor who comes into the courtroom. I actually saw a medical declaration that was used for conservatorship that said, quote, "the person's confused." And that was it. And it seems to me that when we're taking somebody's rights away, we have to be a little bit more sure than that, and we have to be a little bit more objectivized than that. So it seems to me that SB 730 was certainly a step in the right direction. I encourage everyone in this room to keep in touch with us and to test out the efficacy of this bill, because we certainly want to make sure that we're going in the right direction, but I'm quite sure we are. The second question that we have on legal tools is this year we are developing a bill that was actually a companion to the bill last year, SB 731, and you heard a little bit about this bill this morning, SB 1481, which is to develop a dementia-specific probate conservatorship. In this state, there is nothing that is equal between counties. Public Guardians just did a survey and found that there's absolutely no correlation between how dementia people are dealt with in one county as opposed to another. In some counties in this state, you cannot get a placement unless you go LPS. Tragedy here is, of course, if you get an LPS, you can't put the person in the least restrictive environment. You have to put the person in the most restrictive environment. There are some counties in the state that you can't get an LPS if you have dementia. And certainly there are places in the state which you cannot get probate judges to give you an LPS, to give you a probate conservatorship. In some counties, a judge will give a public guardian a probate conservatorship with a person for dementia, but not a private conservator or family member. So what we're trying to do is, recognizing this inconsistency in probate court, is to come up with a more sensitive midway point between an LPS and a probate conservatorship. And basically, SB 1481 in its present form says basically you have to do four things. You have to have a diagnosis of dementia as defined in DSM. You have to have a 730 process. You have to prove that it's the least restrictive environment if it's a placement. And you have to prove that the person would benefit from or needs the medication, and of course we're talking about things like Haldol, medication or a secure environment. And if you have done all those things, then you are able to get a probate conservatorship. Now some people say, well, we can do that in Los Angeles County. And you can. In Los Angeles County, under general medical powers, most judges will give you a probate conservatorship, or at least a public guardian can get that. But the question we have sitting in Sacramento is that the case in every county? And if it isn't, why ought it be just a fluke of geography as to what your placement ought to be? And there's another big issue having to do with that, which is another bill that we passed last year, SB 732, which creates secure perimeters at residential care facilities for the elderly. I have had a lot of providers tell me that I am not going to go into a community and invest that kind of money to develop a secure perimeter at a residential care facility if I don't know that there will be placements there. And if I have LPS placements, I can't have a secure perimeter at a res care facility because it's not a mental health treatment facility. So you get into these little cul-de-sacs, and we're trying very hard to try to come up with the legal tools to be able to have people placed in the least restrictive, most appropriate environment that are sensitive to the family's needs. I have, the Alzheimer's Association, of course, is the sponsor of SB 1481, and we've had numerous stories of people having to deal with LPS, having to come in every year, having to bring their loved one into court, having to renew the conservatorship, having a person with dementia, being placed in a mental health treatment facility in a higher level of security and restraint than is necessary or even good. Third thing we did was to do SB 732 to create the secure perimeters in residential care. We're just getting those off the ground. We hope that these facilities will do the trick. We hope that they will have a plan and Alzheimer's-specific staff and activities, more social model programs, more arts, more tactile, sensory kinds of things. We think that in general they're better placements than nursing homes, although there comes a time, of course, when a nursing home is a better placement. And that kind of thing, those kinds of decisions need to be made by the family members in conjunction with their, with their physician, but they need to have the maximum array of placements available. We need to expand the TBI projects that we have. We have a bill this year, SB 1446. And as I said, it seems to me that people with traumatic brain injury, if there's a link between having a traumatic brain injury and the onset or an early onset of Alzheimer's, we need to be able to treat the person with TBI in its earliest stages, both in a social and medical way. A lot of things, what happens to people with TBI is their whole life falls apart. It's not a medical condition. It's not. It doesn't qualify except for a very short period of time under health insurance. It's not qualified for Medicaid health care, and very often these people are dropped right off the end of the table at the end of the rehab. We need to be able to do better than that for people with TBI. A sixth thing that we need to do is to come up with more funding for CRCs. Caregiver resource centers are, to me, the backbone of Alzheimer's care in the state. And we drastically underfund these centers. They haven't had an increase in many, many years. Instead of $5 million that they have now, in my judgment, they need 10 to 15 million. We're not going to be able to get that money this year, but we hope to get that next year. The seventh thing we need to do is to increase funding for Alzheimer's diagnostic centers. We need to be able to do a better job at that. Eighth, I think we need to refine and expand home community-based systems to place people and care for people with dementia in the least restrictive environments and the most humane environments. Last year we did a bill, SB 547 and AB 1040, called the Mellow Bates Long-Term Care Pilots. And it's a new way of approaching long-term care to try to provide Medicaid services for more home and community-based services. So Medicaid reimbursement for home and community-based services. And if you're interested in that, you should contact me. There's going to be 5 pilot counties that will start up in the state in the next couple of years under the direction of Department of Health Services. And eventually, hopefully, we hope that all counties will be on this kind of system. We need to increase long-term care insurance, not just for people who know that they're going to get Alzheimer's, but for everyone. And I think it needs to be the case that the more risk that we can spread across the population at an earlier age so that the costs for insurance come down, the better off we're going to be. Last year we proposed a bill for tax credits for long-term care insurance. It was a very expensive proposition. It didn't go last year, but I hope to try to go back and get that at some point in the future if it doesn't happen at the federal level first. We need to also do a better job of, it seems to me, of developing the kind of tools for durable power of attorneys, living wills, and advanced directives, as they're called in other states. We don't do a good job of that in this state, in my judgment. The materials, CMA has done, I think, a reasonable job of coming up with a sort of an instrument that people could use, but I think we need to go further. And it's certainly the case that we're never going to end up having an answer for this dilemma about surrogate decision making inside of nursing homes if we don't come up with a better way of doing advanced directives. And finally, it seems to me that we need to risk manage Alzheimer's over the whole population. We've got to do something like a single payer or something like that, so that it isn't a personal problem when somebody gets Alzheimer's or dementia. So it is the society's problem. So that as a society we can make sure that families are not bereft of help and left to cope with this situation by themselves. Without those kinds of instruments and those kinds of healthcare insurance, we're simply not going to be able to get the job done. And the result of which is a lot of higher levels of care than necessary, a lot more acute care, a lot more abuse. And we need to be able to stand up and make those decisions, as tough as they are, and be willing to pay the price that it will cost to have Alzheimer's be a part of the basic universal health care of this state and this country. So with that, I'm going to conclude and open the floor for questions. Yes? The brief overview of the Mellow Bates is that no, I can't. Actually, I can't. If I had 2 hours, I could. Let me do the best I can. What it says is that a county or a multi-county or a sub-county should develop an entity. It could be a nonprofit. It could be a public authority for long-term care. It could be a agency. It could be a consortium of agencies to look at long-term care and the whole continuum of long-term care by blending funds and integrating services. Why should it matter to a a family member or a resident or a patient that, for example, that home delivered meals are the Department of Aging, that in-home supportive services is the Department of Social Services, that home health care is the Department of Health Services. Nursing homes are, of course, certified by by health services, and residential care is over there at social services. You have different intake forms for all of these different services. You have different reporting requirements. You have different agencies. In fact, we have 6 different agencies involved in this. And so what we're trying to do is to say, we need to be able to do a better job of integrating it. We studied Oregon, we studied Wisconsin, Minnesota, and some other countries, and we decided that in a state as large as California, it couldn't be done at the state level. Turf battles and interagency battles would require that that not happen, so we think that going to the local level would work. What's interesting about DeMello Bates is that for the first time that I know of, the consumer has a heavy role to play in the development of these at the local level. In fact, the local advisory committees have to have at least 50% consumers on them. It also has, of course, providers as well as agencies. What we're hoping to do is to take and develop a care manager-driven, not a cost-driven system, so that the care a person gets is in the least restrictive environment in the home and community-based, and it's a shared service that the public is going to share with the family members. And it's a bold move, and it's going to cause some dislocations. I suppose there's the 2 ways or 3 ways I look at it in a brief way is to say it's an unlock in the community, to use sort of an analogy of PACE unlock, to try to extend that out of the bricks and mortars of a single site, but into the community. Another way to look at it is what we call super MSSP. To try to take the idea of an MSSP and make it not only work to keep people out of long-term care facilities, but as well to accept people back from acute care, which is something that we don't do very well. As you all know, discharge planners have a hard time figuring out who to hand the baton off to in terms of long-term care. And very often in this world of managed care, the only people they know about are affiliated home health agencies, which may or may not be their appropriate agency. So we're trying to hope to do here is to have a care manager who's involved in a person who's Medicaid eligible, who has 2 ADLs, or a significant functional or cognitive impairment. So yes, Alzheimer's is covered. And to be able to put the resources of Medicaid, possibly Medicare, if we have a local waiver, as well as possibly private insurance, all into one place so that we can have a coordinated system. And a care manager who is dealing with that person before they go into acute care is the same person that they get back. One-stop shopping for the consumer, and for the providers, a single field of reporting requirements, so that people don't have to, like AAAs, don't have to report to 4 different agencies depending on what the service is. That's a brief overview of what we're trying to achieve with it. Yes, Sam? To the... Yeah, it's already passed. There will be 5 pilot sites. The best thing you can do in the local area, I would start, if I were in Los Angeles, talking to AAA, or you could talk to your health department, or your county welfare director. Los Angeles is going to be very difficult to do. It's going to be, it may be the case that we're not going to have a single agency in Los Angeles. We may have to divide Los Angeles up because it's so large. But I'm going to actually be coming back to Los Angeles in about 2 weeks to talk to the city council about this question, among other things. So, but I think you need to go to your Alzheimer's people, your caregiver resource centers. You need to, to go to providers, try to get the provider community involved, so that that planning can start here. It's going to take a long time to do. These things are not going to be up and running real quick. It's going to take, even in San Mateo, where they have a lot of the pieces, it's going to take probably 2 years for them to get up and running. But I think we need to start the process in every place. So I urge you to get involved in as many different ways as possible. The county or the city will be the ones making the decision. Yeah. Well, as I said, it could be a county agency, it could be a multi-county agency, or it could be a sub-county agency. So the county is the first place to make the cut. It may be the case that county might not want to take this on, so they might hand it over to, say, to one of their cities. And this is certainly the case like in a place like Alameda, where there's some dispute between Oakland and Alameda as to whether they should or shouldn't go into this.
take Medicare patients. They force them to take Medicare patients.
Medicare or Medicaid?
Medicaid.
Medicaid, yeah.
In nursing homes. And it takes them like 2-3 years to be able to get the money.
Right.
And it costs them forever. You know, and secretary and all the mail that has to be done to get it. These doctors are going to get
I think it's absolutely the case, and hopefully this will get around that, because what will happen is the money, it won't be on that kind of cost reimbursement basis. The money goes to the county based on what they would have had in toto, and then an agency would dole it out. Okay, so who's checking on the nursing homes? Well, of course, the county and the consumers will be involved. The unit that I'm talking about, a public authority for long-term care, the consumers and the family members will have 50% of the vote on that. So, hopefully they will be, be in their best interest to be vigilant.
some of those poor dear nursing homes don't even have any family members that go to see them.
That's true. We have representatives of people. I think we're doing the best we can with that. There's certainly going to be cases where people are going to continue to fall through the cracks. I don't think we're being a Pollyanna about it, but I think that the less impediments that we place in the way, the less fragmentation. It's in nobody's best interest to have fragmentation. We have 5 minutes left, or at least that's my score. I noticed I was going down. No, 1. I can't even get a safety here. Yeah.
You're kind of moving towards the British Columbia universal long-term care model with the integration. Is there any attempt in the future to integrate the facility?
Yes. Mellow Bates gives preference to a county that will integrate acute care and long-term care. And we did a lot of research on what Minnesota's doing. You mentioned Columbia. There's also a Boston model we looked at. And we think that this is feasible. And in fact, it'll stop cost shifting. It'll put the incentives and an emphasis on the least restrictive home and community-based care side, and it will induce people to really take care of prevention. One last question? No? Okay. Thank you very much.